Hello, everyone. Welcome to I don't know which number this is, but it's the final in our series of new work in concepts of health and disease. Today, it's my great pleasure to introduce Cecily Whiteley. But first, a couple of quick thank yous. So first off, thank you to the Peter Sowie Foundation, who fund everything we do, including this series, this colloquium series. Also, thank you, as this is the last one, to Rivka Hatchwell, who has done an amazing job of organizing the whole series, and none of it would have happened without you. Work. Can I just double check that people who are listening remotely, that you can hear me? Could someone either give me like a thumbs up with the icon thing, if you can, or pipe up if you can't hear?
You got a yes.
A yes. Okay, good news. Thanks very much. Okay, so Cecily will be giving a talk titled Prospects and Challenges for a Global State Model of Depression. Over to you.
Amazing, thank you. And thanks everyone for coming. I feel honored to be the last presenter. So what I want to do today is talk about and give a brief overview of a research project that I'm engaged in, which is good primarily around providing a new view or early model of depression. And what this does is aiming to bring research, long-standing research in philosophy of psychiatry and in psychiatry on the nature and neural basis of depression into closer contact with work which is going on at the moment in consciousness science. So what I'll do today is give an argument or motivations for thinking that this hypothesis, which it is in fact a hypothesis, not a conceptual analysis or something, I'll look at the motivation for thinking that the hypothesis is a good one to begin with the sort of caveat that a lot of the empirical work, which is going to shed light on the ultimate viability of this model, and some of which I'll sort of sketch later, which is in progress with collaborators of mine. So with the caveat that that's not yet here, but what I hopefully want to achieve is hopefully get you to all think that this is a reasonable hypothesis and a promising line of research which we should look into further, both as philosophers interested in the significance of what some philosophers call wakeful consciousness, and also for those working in philosophy of medicine and philosophy of psychiatry. Okay, so it'll be useful, I think, to start off, given the audience is mostly philosophers, by distinguishing the question which I'm interested in primarily about depression from a variety of other questions which have been talked about in philosophy of psychiatry. When depression is mentioned in philosophy of psychiatry in the last 30 years, often it's raised in the context of broader issues in philosophy of psychiatry concerning the nature of mental disorder. So I'm sure that this is something which has come up in this series already. So what are mental disorders? And then here you get into a broader debate, which I know many of you are interested in, about the nature of pathology in general, and how do we distinguish between pathological and healthy conditions. So you might think in the context of mental disorder, there's a big debate about whether we can understand mental disorders in terms of brain dysfunction, or whether we need to introduce an evaluative component, right, to our concept of mental disorder. And then there's my favorite question, which I'm not going to be looking at today, which is whether major depressive disorder as a diagnostic category is a natural kind. So here we have questions about, more general questions about the classification that we get in psychiatry and its legitimacy as a classification of mental disorders. So you can ask, is major depressive disorder, does it have the same status as something like a biological category, like biological species, or is there a sense in which the classificatory schemes that we find in psychiatry, whether they're gerrymandered or made up and not reflective of the real structure of reality? Right, so those are just some questions which I'm going to put to the side, even though I think what I will have to say about depression will definitely affect the last question, but I take what I'm saying about depression to be consistent with multiple different answers to the first two questions, right? So I'm sort of staying neutral on those. Okay, so the question that I'm going to be interested in, what I want to tackle, is this question about what is depression. So if you think about trying to ask questions about whether depression is a natural kind, seems to underdetermine in an important sense about what the nature of depression disorder is, right? So this is a question which Elsaline here in one of her papers talks about in terms of distinguishing one mental disorder from another, right? And partly what's built into this is a question about its neural basis. So what's the neural basis of depression? So that's the question which I'm going to look at. Okay, so in the beginning of the talk, I want to sort of sketch what I see as a pretty dire epistemic situation with respect to that question about what the nature of depression is. So I'm going to start by looking at the conception of major depressive disorder that we get in the DSM. And this may well be familiar. But basically, if you're going to be diagnosed as depressed in a clinical setting, you'll most likely be diagnosed primarily in the first instance on the basis of possessing one of two core symptoms. So the first of which is depressed mood, and that goes on to give depression. Its status is what's called a mood disorder in psychiatry. And if you're wondering what that is a good question to ask. And the second core symptom is a markedly diminished interest or pleasure in almost all activities. So patients must have one of these core symptoms for at least 2 weeks. And then there's the usual caveats about not being better attributable to another mental diagnosis, medical diagnosis. And in addition to those two core symptoms, patients must have at least 4 out of the following, right? So these are going to be probably well known to you. So patients must show considerable weight loss or weight gain, which corresponds to decreases and increases in appetite. There'll also be sleep disturbances resulting in insomnia or hypersomnia. Patients may have fatigue or loss of energy. They'll have feelings of worthlessness or guilt, which may be delusional. Patients often show diminished ability to think and concentrate or indecisiveness. And then there's the sort of more obvious ones about recurrent thoughts of death, suicidal ideation, and the individual has made a potential suicide attempt or specific plan for committing suicide. So looking now to how this has influenced and how this guides empirical neuroscientific research on the nature of depression. So what has tended to happen, it's been going on for at least 30 years, is neuroscientists and those working on the neurobiology of depression have started with this operationalization of depression as this mood disorder. And they've then gone to look at what sort of mechanism can we find in the brain, which explains all the symptoms that we've just looked at, right? So, and so far, the search for this unified mechanism, which is going to explain the symptoms of depression, has not been successful. But nonetheless, there's been really excellent research done on identifying a large number of biomarkers which correlate with the onset of depression. So these are sort of a variety of different things, but sort of key candidates include sort of neurotransmitters as markers, there's inflammatory markers, markers of oxidative stress, and disturbances to the sleep-wake cycle, right? But still, there's kind of widespread skepticism about whether these biomarkers are really going to give us this sort of unified mechanism which people are looking for. And more recently, people have suggested that the situation is actually even worse. So you might think that in an optimistic vein, you have these biomarkers that they predict the onset of depression, but even though they're maybe not explanatory in the sense they might explain why these symptoms are co-occurring, they might still be sort of predictably successful at helping us diagnose and find various risk factors for the onset of depression. But nonetheless, there's been quite a few meta-analyses like this one done by Pinnis et al., which suggests that these biomarkers are not even good at doing that, right? So there's sort of widespread skepticism about this program of research, which is aiming to find this neural mechanism, which is guided by the DSM conception of depression. And so you might think that there's a bit of an impasse in psychiatric research when it comes to depression. And this is something which I've found out from speaking to various psychiatrists. You really see people on all ends of the spectrum. On the one hand, you say, well, no, we're continuing on as normal, it's fine. This is just a sort of matter of time, and we'll get there. And then on the other side, you have people who tend to be influenced by the research domain criteria and analogous lines of research, who say that what this shows, this lack of evidence for this mechanistic explanation of depression, is that we should really be skeptical about the validity of depression as a category of thing, right? So just a few weeks ago, I was speaking to a colleague in neuroscience, and well, everyone knows that depression is not real. And I thought, okay, well, that's a good starting point and a good anecdote. So the question that I want to start with then is what should we do? Where do we go from here? So should we continue the search? Should we just carry on as normal? And with the sort of understanding that we know that the DSM is not perfect, but nonetheless, we should sort of just continue in the same vein? Or should we do something more radical, potentially along the lines of an RDoC, but type framework, of being very skeptical about the nature of depression as a category and just sort of going from the ground up? So what I want to suggest is a third option, which I think we can get into this in Q&A if that's of interest. I think it's compatible with components of both approaches, somewhere in the middle. And the approach is motivated by asking the following question, right? So do we have the conceptual toolkit currently to properly understand and operationalize depression to begin with, right? So the idea is not that we should be skeptical necessarily about the nature of the category, but we need to ask questions about whether we're conceptualizing the sort of core features of that category correctly. So phrase in terms of the DSM and the sort of corresponding mood disorder label that comes along with depression, we can ask whether mood is the correct ontological category for analyzing and making sense of depression, or whether we need something else. Okay. And that's just to say that if we're not operationalizing the phenomenon correctly to begin with, that might explain, right, rather than saying the category is not real. That might explain why the search for the unified mechanism, which explains the various symptoms of depression, has not been successful, right? Or it might explain, for example, why researchers may be looking in the wrong place and at the wrong level of explanation. Okay. So that's my sort of question. And how I'm going to suggest that there is a sort of missing concept that can potentially unify and hopefully improve the current situation we have with respect to depression. But before I get there, what I want to do is look at the work of this philosopher, Matthew Ratcliffe, who's done a lot of really great work on looking at the detailed phenomenology of depression. So what is it like to be depressed, right? And how does conscious experience change when patients become depressed? And so the sort of motivation for starting with this is when you look at the DSM, you look at the core symptoms of depression, you get lots of symptoms, which pretty much all of them make reference to subjective changes to conscious experience. So you have a change in mood, you have a change in thought, you have a change in feelings. So this suggests just naturally that in order to better understand the nature of depression, we should look a bit more closely at the experiences which are associated with it. Okay. So what Matthew does is he has gone and interviewed a great number of people with collaborators in psychology when he was at Durham University, as well as reading lots of memoirs and so on, and has tried to provide an account or a description of what people say depression is like. Right? So in this book, he has this sort of core idea, which is that depression is associated, or the onset of depression is associated with a fundamental shift of conscious experience. Right. So this is his quote. So he says, sufferers consistently indicate that depression is qualitatively different from what many of us regard as everyday experience. This is the depressed person finds herself in a different world, in an isolated alien realm that is cut off from consensus reality, where people have more mundane experiences of feeling more X, or sort of more happy or more sad than usual, right? So this is what these reports that he's looked at show is that depression seems to involve a disturbance to something that's more fundamental to our lives, something that goes unnoticed when intact. Right? So this is what seems to be lost or eroded is a sense or feeling of being comfortably immersed in the world. So he says, as part of this shift, so he says, what we get when we look at all these reports is this presence of this fundamental shift to conscious experience. But within this shift, we can make sense of sort of core phenomenological dimensions of which experience is changing. So some of these link back to the symptoms that you get in the DSM, but some of them are quite broader. So we have changes to bodily resonance. And then he distinguishes various different types of change along this dimension. There's feelings of hopelessness change. And in particular, one of the things he highlights is that there's a loss of an ability to hope when you're depressed. So it's not just that you're feeling hopeless. The idea is that people report a loss of an ability to even have any kind of hopeful feelings. And this sort of relates to the phenomenological changes that you see with regard to sense of agency and free will. So here again, you have, it's not that acts seem hard, but that acts seem impossible. And this is a sort of impossibility which affects the way the world's experienced when you're depressed. So the world, in one way of looking at this, is to say, you might think, to interpret this in more philosophical terms, you might think that what Ratcliffe is highlighting there is something about perceptual affordances for action. And then there are, of course, the changes to experience of time. So a sort of key dimension of the phenomenology, according to Ratcliffe, is the sense of time slowing down. Or, so the idea, it's not just that you're sort of, the talk of people when they're saying when they're depressed that everything just seems to be going on forever, is something literal to that, right? The idea is that the time literally feels like it's just stopped or slowed down very dramatically. And this affects the way the future is experienced. And then corresponding to these, there's dimensions relating to feeling guilty and the sort of self-narrative that what one's feeling with regard to oneself. And then there's related changes to the structure of interpersonal experience. So there's a sort of feeling of estrangement from the world. The idea, and this is sort of goes along with these reports, which are often very elusive, which suggests something like, I'm in my own little world, a world that's away from the real world. I'm sort of alone and I'm isolated. Okay. So what we get from Ratcliffe, I think, are these sort of key ideas. The idea that the experiences that occur when people are depressed are not continuous with ordinary experiences of sadness or low mood, right? So this is the sort of core claim. So that what it suggests when you look at these reports is that there's a sort of fundamental shift to experience, which doesn't seem to be in the same sort of continuum with the sort of everyday experiences of feeling happy or sad or low. Okay. Second, that the alterations to conscious experience which occur after the onset of depression are far more wide-ranging than the DSM suggests. So this is sort of one of the take-home messages from Ratcliffe's book. And related to this, these alterations relate to one's mental incapacitation often, right? So the phenomenological dimensions that Ratcliffe highlights often suggest there's a relationship between the onset of depression and becoming incapacitated in various ways. So there's a loss of an ability to hope there's a loss of ability to, or perceived ability to perform various actions. And finally, something goes wrong, according to Ratcliffe, when we try to reduce depression to these phenomenological dimensions. So you have people say, okay, so depression is just a matter of this, this, and this, and this. And they say, well, this seems to miss something out, something very important, right? We need to make sense of, when we're talking about depression, a sort of holistic change to experience, in which the dimensions of change are to be made sense of in terms of. So when I read Ratcliffe, I thought, okay, this is great. We can definitely, these are definitely important data for psychiatrists and philosophers interested in depression, right? But there was a sort of puzzling question about how do we move from this work in its phenomenological domain. So Ratcliffe puts forward this view of depression in terms of as an existential shift, which is along the lines of famous phenomenologists. But it's not clear how we're supposed to use this in psychiatric research. So there's a question about what can we do as philosophers to make this research from phenomenology more empirically tractable, right? So is there a way of explicating this research into a way which can bring it into line with research on the neural basis of depression, right? So is there a concept which we can utilize, which can help us connect research in this phenomenological domain to neuroscientific work? Okay. So the concept that I want to use is that of a global state of consciousness. So those of you who are familiar with consciousness science will know this well, or have literally talked to me for 5 minutes probably, will already know what this is. But this is a concept which is one of the key explanatory concepts of consciousness science. So the consciousness science is looking at the neural basis of consciousness. What do we mean by consciousness? Various different things you can mean by consciousness. One of the central types of consciousness which is being studied in consciousness science is the changes to your conscious experience which occur when you're awake versus when you're in a dream. Right? So we have two concepts here, right? This wakefulness and dreaming. And within this broader family, consciousness scientists usually refer to things like meditative states, psychedelic states, and perhaps things like drunkenness. So the concept of a global state of consciousness is something which is the broader category to which all these things belong to. So you think about the phenomenology associated with waking up and entering a distinctive state. This concept of global state of consciousness is going to pick out the distinction between the state of consciousness you were in if you were dreaming before waking up, and the distinctive state of consciousness you've arisen to when waking, right? And I think it's important there to say that these states of consciousness can dissociate and often do dissociate from various states of arousal which characterize the sleep-wake cycle. So I think that one of the easiest way of motivating this is to look at what's called disorders of consciousness, so hence the title of my paper on it. So here you have sort of persistent vegetative states and minimally conscious states. So you have patients who are showing evidence of the sort of usual sleep-wake cycles. They seem to be waking up in a biological sense. But the distinctive state of consciousness, which usually accompanies waking up in this biological sense, is absent. Okay, so what are global states of consciousness? So this is a topic in consciousness science, which has been going on. Oh, I can't get rid of that. Which has been going on for a while, like this question about how we should conceptualize and think about global states of consciousness. So what I want to draw on here is a move in this line of research, which started with a conception of global states of consciousness as being understood in terms of levels. So the idea is that at one level you have the lowest level, you have something like coma, and at the highest level you have psychedelic states, and then wakefulness and dreaming are to be understood somewhere along that continuum. Right? More recently, this is the account that I want to look at, this view of levels of consciousness has been abandoned, and instead, the idea is that we can understand global states of consciousness as multidimensional phenomena which fall along various different dimensions. So they're sort of occupying this spaces in this multidimensional space. And more recently, people have added to this sort of multidimensional view of global states of consciousness the idea that we can understand these dimensions which frame the global state space in terms of capacitation, dimensions of capacitation, right? So the idea is that when we look in at subjects who differ in different states of consciousness, we find that they vary along different dimensions according to capacities for various different types of content. So we have families of dimensions which relate to sensory content and cognitive content. And then we have a variety of subjective dimensions relating to, or sort of phenomenological dimensions relating to the subject's experience of time, to their experience of self, and their experience of the sort of unity of consciousness. And these correspond to various functional capacities. So just as an example, capacity to have information globally available to one. So there's an emerging account here, I think, which suggests that there's a view of global states of consciousness, there's these capacitation states, corresponding to various dimensions, some of which are phenomenological. And the challenge for consciousness science on this view is to look at the neural mechanisms which are explaining these changes. But where does this leave us with respect to depression? So the idea which I want to put forward and which I've been working on for the past year now is this idea that depression is a disorder of consciousness, in the sense that it is the change to a subject's global state of consciousness. Right. So the idea is that when an individual becomes depressed, the changes that occur in her mental life are going to be the same sorts of changes that occur when she departs from a state of wakeful consciousness and starts dreaming, or when she enters a psychedelic state. Right. And in particular, the idea is that where subjects usually occupy a state of wakeful consciousness, they're in fact in this depressed state, this disordered state of consciousness. And I think that this can accommodate a variety of claims we know to be true about depression. So when we're depressed, so this is sort of the standard response to this is like, well, how, if you're depressed, can you be awake? How can you still dream? And what should we say about the sort of transitions between being awake and being depressed, right? So I think we've already mentioned the first one about how we can still be awake, right? And that's just to make this conceptual distinction between being awake in a biological sense and being awake in a sense of being in a particular distinctive state of consciousness. And it also can capture why or how the people who are depressed can dream. Right? So the suggestion is not that when depressed individuals are in this state, they're in this state continuously. The idea is that when subjects awake from, for example, a dream, they occupy not the sort of distinctive healthy state of wakeful consciousness, but a disordered state of that kind, right? And I think there's kind of a lot of research going on at the moment about the nature of dreams in depression and how those change. And I think this is, again, something that this can speak to. Nick, how long have I been doing? Great. Okay. So I think we can begin to see the beginnings of the view. Right? So we have an idea that there's this distinctive state of consciousness associated with the onset of depression. This takes the place of wakeful consciousness. And there's going to be, like consciousness scientists and philosophers are trying to do with distinctive global states of consciousness like psychedelic states, there's going to be a distinctive phenomenological profile which maps onto the variety of different dimensions which we saw are happening with respect to psychedelic states, for example. Right, so we can take, I think, Ratcliffe's work on the phenomenology of depression and make sense of it in terms of the phenomenological dimensions of the distinctive state of consciousness associated with depression. Okay, so that's the sort of general outline of the view, and we can go into more detail in Q&A, but I want to sort of spend the last 15 minutes talking about what the implications of this conceptual shift are. So what can this do, and why as a philosopher do I think that I can have any effect on this research? So I think there are sort of 5 different, and I think this is sort of temporally ordered in a particular way, 5 different sorts of lines of research which I think that this conceptual shift can influence. So the first one is concerns the personal understanding and communication of depression. So this is something which I really did not realize that I was attempting to do or had anything to say about, but something which has been sort of reinforced in feedback from writing various things about this. So something that Ratcliffe also mentioned in his book was that sufferers who are diagnosed with depression often complain that there's a sense of alienation associated with depression. And this sense of alienation is not just about the phenomenology of depression. It's not just about being, I actually feel like I'm detached from the world. But there's also sort of failure of interpersonal communication in the sense that it's very hard to explain to someone who is not depressed what's going on, right? So there's a sort of, and this is related to the sort of standard way of conceptualizing depression as a disorder of mood. The idea here is that if I say I'm depressed and I say, well, I just got a low mood, that's not really going to tell you how I'm feeling. Oh, that's the idea. That's what they say. So you get this sort of common complaint. So it's hard to explain depression to those who haven't experienced it because it's not sadness, right? So how might this conceptual shift that I'm talking about and trying to motivate over the next 5 to 10 years, how is that going to help, right? So the idea here is that, well, not everyone's been depressed. Most of us, I think all of us, will have experienced alterations to our global structure of experience. So unless you're very unusual, you will definitely have dreamt before, even if you can't remember it. And more likely, you'll have also experienced disruptions to the global structure of experience while being awake in a biological sense. So if you've been drunk, for example, I was told once never to say that I have experienced drunkenness, but it's ridiculous. So the idea is that we've all experienced these things, even if we haven't experienced them in exactly the same way that the depressed person has. We should still be able to understand. Okay, now I can imagine what it's like, being trapped in a bad trip, for example, and that can help us relate to those people who are suffering from depression. And so this is something which I've got really lovely emails about. People who are watching their young child or teenager suffer from depression. And now I can really understand what they're going through. Now I understand. So that's something I think which can happen right away. So we don't have to wait too much for empirical research to start doing. And even if it's entirely wrong, it's been somewhat beneficial. Okay. So what about some more concrete implications? So one of the things that I looked at in the original paper on when I put forward this idea is the extent to which this model of depression or view of depression can help us explain the success of psychedelic psychiatry. So I don't know how much people know about psychedelic psychiatry. It's pretty much self-explanatory. you give psychedelics like psilocybin to patients who are diagnosed with depression and other mental disorders. And often these are going to be patients who are treatment resistant. So the existing treatment options are not working, which is a large number, disturbingly large number of patients with depression. And given psychedelics under therapeutic conditions. And surprisingly, psychedelic psychiatry, and at least in the sort of early clinical trials, seem to be very positive, right, in relation to existing treatment options. So I should have mentioned this earlier. The existing treatment options for depression are famously bad. So you have, in a generous look at the data, you have success in about 50% of cases with a joint treatment of therapy and antidepressants. So psychedelic psychiatry, which is showing lots of excitement, seems to be showing all these very positive results, particularly with respect to depression. And this raises a sort of question for philosophers and for psychiatrists and neuroscientists, which is, why is it working? What's the mechanism of action for psychedelics? And this is the subject of a recent book on the philosophy of psychedelics by Chris Letherby. So I won't go too much into detail about Chris's work, but what I think that this view of depression does, I mean, one, I think there should just be some skepticism about the project of trying to explain the mechanisms of action for psychedelics, given the heterogeneity of mental disorder. I think that's something to think about from the outset. But at least with respect to depression, I think that what this view of depression as this altered state of consciousness does is that it suggests at least one level of explanation, which you might want to appeal to in thinking about the efficacy of psychedelic psychiatry. And that's the idea of resetting a patient's global state of consciousness. So lots of the neuroscientists who are working on psychedelic psychiatry right now often talk about this reset, that psychedelics are resetting in some way, right? And that definitely seems right when you look at the neuroimaging. But what this view of depression does is it gives you a slightly different way of looking at what's reset. So the idea is that you think about if, for example, depression is this being stuck in a bad trip or bad dream that you can't wake up from. What psychedelics do is that they radically alter the structure of one's conscious experience. They propel one into this distinctive state of consciousness or states associated with psychedelics. And then the question is, when they come out of this trip, where are they emerging to? Like, what state of consciousness are they emerging to? And the idea is that what that might do, and there might be a very good explanation there about resetting the mechanisms which regulate these global states of consciousness, such that this sort of healthy state of wakeful consciousness is restored. And that, I think, is compatible with a variety of different proposals about the sort of neural mechanism of action, right? It might be that these are sort of different levels of description for the same thing. Okay, the final one that I want to sort of talk about in detail is the implications that this conceptual shift has for immediate research in neuroscientific psychiatry. So we go back to the beginning. What we have is this sort of impasse, but what should we do as, for example, neuroscientists working on the neural basis of depression? How should we structure our research? Should we go our dark route, or should we just continue as usual? So what I think, and this is something which I'm quite excited about, given I'm working with a number of consciousness scientists, is to try and bring research on the neural basis of depression into much closer contact with this research in consciousness science and the neural basis of consciousness, right? Or the neural basis of global states of consciousness. Right? So what sort of obvious thing to say is that the researchers in consciousness science haven't yet identified a neural mechanism associated with these changes in consciousness, right? But there's a lot of sort of research going on, and I think that we shouldn't be disheartened about this lack of progress. I think it's sort of going along the right line. And it also gives us reason to reflect on thinking that, well, we shouldn't be that surprised about not having a neural mechanism or mechanisms which explain depression, because we haven't yet got the NCCs for any global states of consciousness. But nonetheless, there's sort of room for bringing a lot of this research together. So I think we can sort of be cautiously optimistic about this research. And I think there's a lot to learn from both sides. So psychiatrists working on depression can make use of a lot of different biomarkers of NCCs and vice versa. So if anything, even if you're very, very skeptical about this concept of the global state of consciousness, you might think that there's enough room and sort of explanatory purchase to this hypothesis that you might at least want to use the data that they're using in your research program, along the lines of sort of precision medicine or something like that. What time are we on now? Okay, cool. Well, I will very quickly back up. So what I wanted to finish with is sort of the obvious challenge for me, or for anyone who is interested in this idea, is to try and gather evidence which is going to shed light on its empirical viability. Right? So that's something which I'm engaged in right now, and hope to be engaged in for a good few many years. So I have, I was going to sketch some paradigms for thinking about testing the hypothesis. That I'll mention at least one. So one of them. So one way in which you might think that we can gain support for or evidence against this hypothesis is by looking at the experiences associated with psychedelic experiences. So this is my collaborator, David Yarden at Johns Hopkins. And so he suggested to me very early on is a sort of an obvious way of going about getting evidence for this is just to use a lot of the sort of standard subjective tests that they are using to study psychedelics and psychedelic psychiatry. So there's sort of variety of standard subjective tests which are used to probe these experiences. And they differ very substantially from this if you give the same subjective test to healthy, normal, sober patients. So the idea is to use these sort of, which they're standard in psychedelic psychiatry, and give them to patients with major depressive disorder, and you'd hope to see if there's a sort of similarity of psychedelic experience and depression experiences, these subjective tests are going to yield different results. And then there are sort of other ones that I've got going on, which are a bit more invasive, but we can talk about them later. And then there are sort of various challenges, and this is just here to invite discussion, which you might want to press me on, which is on sort of more conceptually precise account of global states of consciousness. And related to this is this question, which is one that I'm working on at the moment, which is if this global state of consciousness view of depression is right, why the hell does depression feel so bad, right? If it's a mood, there's going to be a straightforward explanation for that, right? Moods are affective, paradigm affective states, right? What's going to explain this negative phenomenology on that view? And then there are a bunch of other questions, but I'll leave it there.
That should be fine. So let's move to Q&A. I'm not sure that people watching remotely will be able to hear questions from the room. So I'm going to try and repeat them. So don't make them very difficult to repeat. And if you have a question and you're watching remotely, the best thing to do would be to use the raise hand function. So if you go to the participant window, you should be able to do something like a raise hand. If you can't find that, just put a Q in the chat. Alternatively, you could actually just type out your question in the chat and I will read it out. So if you have a question in the room, just raise your hand and I'll note some down. Okay, so why don't we start with Arjun, but just keep your hands up while I note them down.
Thank you.
Yeah, go for it.
But there are different states of consciousness which do not have a negative affect. We don't think that people are depressed when they say take fentanyl. So the depressed state of consciousness doesn't seem to be sufficient for capturing depression, if that's true.
Okay, interesting. Yeah. So
Can I try summing that up for the
oh yeah,
for the
sorry,
listening
sorry.
So the question was about depressed states that might not have negative affects. The example you was having taken fentanyl, and how these sorts of examples would fit within the picture.
Yeah, I think that's a great question. So on the one hand, I'm like, that's great. I don't have to explain the effect of phenomenology of depression. But on the other hand, I think there's a problem. So I mean, so the one obvious thing to say is that, while is to question the sort of question I didn't want to talk about, which is whether there's a natural kind associated with depression. And it seems most obvious to me that where we talk about depression, there isn't going to be something like the depressive state of consciousness. In the same way that when we talk about dreams, there's not going to be the state of dreaming, or the state of psychedelic state, right? Rather, what might be helpful here is to think about, and maybe this will help, think about depression as a sort of temporally extended process involving a sort of series of distinctive changes to one's global state of consciousness. So how would that help? So, I mean, one idea is to say that whilst not all depressive experiences have negative affect, maybe they have, maybe there are sort of parts of the temporal process which constitute depression, which don't have negative affect. Another thing to say is, an alternative thing, is to say that there are maybe just distinctive states, which we have currently lumped together, in the same way as like no one psychedelic experience is the same. And maybe you can have very different experiences associated with psychedelics in virtue of being in distinctive global states of consciousness. But there's a sense in which we can still group these together as a broader kind, even though when it comes to treatment, there's going to be very important reason to differentiate them. Does that help?
Okay, next question.
Yeah, thanks for this. This was all very new to me. So would you expect the global state model of depression to give depression a different extension to the current sort of DSM diagnosis? So people would end up being, matching enough to the DSM criteria to be diagnosed as depressed, but they don't all have this different global state of consciousness and vice versa. And how would you think that was a problem or benefit?
Yeah, excellent. So,
just repeat it for
sorry,
the remote people. The question, I think, was does this model have the same extension? Would it count the same states as depression as, say, the DSM model? And if not, would that pose a problem?
Yeah. So, yeah, really love this question. I would say, no, it's not going to have the same extension. And no, I don't think it's a problem. So I think very few people think that the DSM is correctly carving out. And that's a sort of, I think, a generous way of putting it. Think that it's generally picking out categories which are not going to go under any more revision. So that's just one thing to say. But yeah, so I think, and this is sort of part of what's going on with this whole worry about the nature of depression being so heterogeneous, is that the phenomenology of depression does seem very different when you get some cases from others, right? So what would I want to say about that, right? So I think I'm fine with saying that in many severe cases of depression, there is this global shift to experience, and these are often associated with entrenched depression, so depression which is just sort of recurring, and often treatment resistant. I'm okay, and I don't think it's a problem for there might be at all, that there might be cases of depression, which we currently diagnose as depression, which don't involve global changes to one's global state of consciousness. Yeah, so there might be some the very broad end of the spectrum, which literally are low moods, and some which are maybe intermediary. So there might be, and that's sort of where I was sort of alluding to this extended process. There might be sort of mild depression, which, yeah, is, I suppose, the most common form. You might want to call it high functioning, where there is this sort of very elusive but nonetheless shift to experience, but you've not yet got to the place, which is what people often report as being this most severe, different world.
Okay, I'd like to take one from online. I just can open the chat. That was so. Okay, so there's a question from someone online called Jay, and the question is: does this global consciousness model hypothesis open up to the possibility of a non-physicalist level of interpretation and explanation?
Fascinating. Yeah, so I mean, one part of me as the philosopher of mind is like very stressed by the notion of non-physicalism. It's triggering. But so the things I suppose I have to say is that I take everything that I'm saying to be compatible with physicalism. So it's a physicalist naturalistic project. There's going to be a sort of naturalistic explanation for these changes. We don't have to invoke qualia, depending on how you go. But what you're saying about this non-physicalist level of explanation, so what I would want to say is that there is a level of explanation, which is a scientific level of explanation, which is required in order to make sense of depression. So there's sort of a level of explanation, which is going to make reference to changes in experience, which is going to be needed to explain depression. So just to sum up, because that wasn't very clear, I want to say no to non-physicalism, but yes to different levels of explanation.
Okay, and I can see a couple of hands raised. So Thomas Crowther, if you could unmute yourself, and we'll just check that we can hear you clearly first.
Hi, Cecily. Can you hear me?
Hi, Tom. Yeah, I can hear you.
Yeah, okay. I had lots to say. I'll try and keep this short. One of them was one question I just wanted to ask you about. You had a slide which suggested if it was the one where you had depression with sleeping and waking on the.
Yeah. Sorry. Let me. Was it this one? This one.
That one, yeah. Can I just ask you about that for a sec? Yeah. So, because I suppose one might have different thoughts when one thinks about depression as a disordered state. So one thought is, particularly in the context in which you talk about it, so one thought is that it's let's say a disorder of the waking state. But another thought that one might have about it, which looks to be suggested by your slide, is that it's a disorder of transition. So it looks like on this that the state itself is a disordered transition between sleeping and waking. And I guess I just wanted to ask you whether that is how you wanted to think about it.
Interesting. Okay, so I guess it would be helpful to know a bit more about what that's going to imply about whether I say one or the other, right? So I was thinking of saying very much in the first sense that you're talking about. So
yeah, okay.
How I was thinking of it is that there's this neurobiological state of wakefulness. It plays a variety of different functions.
Yeah.
And this depressed state is taking the place of that state. So whether that means it's a disorder of transition, I'm not sure.
I suppose that it looks, perhaps I was just reading the diagram a bit too literally, but it looks like it kicks in at a certain point in the cycle. I mean,
Okay.
so for example, I mean, I guess the follow-up question was, would that make depression some kind of variety of some sort of variety of parasomnia, right? Where we think that NREM sleep behavior disorder is people don't wake up properly.
Yeah, great. Yeah.
Okay.
Yes.
Yep.
Yeah, I mean, yeah, I think these are all great questions and things that I guess I'm thinking about. So really, I suppose I want to be open right now about many different ideal ways of classifying these global states of consciousness. So one way in which to go is to say that there is a lot in common with parasomnias and depression. In the way that I think there's a lot in common with depression and dreaming. Insofar, and what I mean by that is insofar as they are to be analyzed and made sense of at a particular level of explanation, right, in terms of these global changes. I don't know. So, I mean, I don't know. When I've spoken to people before about this.
I look, I had loads of other things, but I'm going to be a good seminar participant, and I get irritated when people do this. So if there's time at the end, I've got another question I'd like to ask.
And I will, if not, we'll have a chat.
Okay. So back to the room, Dimitri.
And thanks for really this. So the question is about something you mentioned in the first part of your talk. So when you said that there are obvious problems with these non-holistic ways of looking. You said that there are obvious problems with non-holistic ways of looking at depression. We usually ask for a holistic view, and I thought about those non-holistic views as like looking at several symptoms or factors that we think mark there's depression in a person, and try to explain why they come about, maybe how they relate to each other. And we're just wondering, like, what are these obvious problems with this approach? Because it didn't quite get shared.
I'll just repeat it for you. So for those listening remotely, the question was, when Cecily was speaking about the sort of non-holistic views, that are not the view that she's proposing, there are all of these various different components that are supposed to be unified together. And I think the question was to ask for some clarity about exactly what's wrong with that kind of approach.
Yeah, that's great. Yeah, so I think that there's a sort of conflation here between that complaint about a view about being disparate and this view of the DSM and disorders in general as being clusters of symptoms which are underwritten by mechanisms. So the thing that I was challenging was, I don't think I was challenging, I think I was reporting on what people say about the attempt to reduce depression to the dimensions of experience, which Ratcliffe has picked out. So if you say to someone who's depressed, so if you ask them about what their experience is like, they'll report this variety of things. You say, so is that just what it is? Is that what it's just like to be depressed? Sorry. Sorry. Oh my goodness. What's going on? Okay, are we safe?
Last 5 seconds.
Yeah. So what I was saying about so I think what you're talking about is this. Oh God, this thing, yeah. Something goes wrong when we try to reduce depression to these phenomenological dimensions. So that is a report about what people say about their experience vis-a-vis these things. So that I think is quite a different claim to a criticism of the sort of standard way of looking at mental disorders as clusters of symptoms and mechanisms. So in the original paper, I looked at how my proposal might fit into that sort of standard debates about those very things that you're talking about. So I think it's compatible with the view that we view this depressed state of consciousness as a distinctive symptom, if you want to go that way. It's also compatible, so that's compatible with like what you might call descriptivism in philosophy of psychiatry, and it's also compatible with sort of more causal, medical type views, views which see what the nature of mental disorders to be the causes of the symptoms, not the so good to clarify that. It wasn't.
Alex?
Thanks, I really love this. It's really interesting and it's been good to me. I think this is clarificatory. So I just trying to understand a bit more the difference between kind of changes of mood and the kind of global state changes. And I'm wondering, so the first part of the question is like whether or not that's a kind of matter of degree or some kind of more fundamental distinction, and kind of the related aspect of the question is, it seems to me, for example, that, I mean, you know, a tiny bit of degree, but it's pretty determinate whether you're awake or asleep. Whereas, say, drunkenness or even being on a psychedelic admits that you can be more or less tripping. Like you can be more or less high, you can be more or less drunk. But it's like, I'm not sure you can be more or less asleep. So then thinking about depression, it feels like you need more or less depressed, but perhaps I don't know quite how that would fit into whether or not you think it's more like the sleep awake side, or you think it's more like the drunk, not drunk. Maybe you think the relevant kind of drunkenness really is, you know, you're actually like totally out of it, not sorry about that.
Let's see how I can be. So I think the question was something like, for those listening at home remotely, some global states of consciousness seem to vary by degree, like drunkenness or being high. Some global states of consciousness seem to be a bit more binary, like being asleep or awake. Where does depression fit within this? Is it more like one or more like the other?
Much better.
Fantastic. And there was also a first question about mood, which is what distinguishes mood from global states of consciousness, which is the question. Well, for a while I thought it was the question, and now I've kind of lost, you know, when you think about something for so long, you kind of lose its significance. Not that I'm sort of guessing myself whether it really is that significant. So on the mood thing, so the obvious thing to say is that they're just doubly dissociable. So some people say, so what's the difference, right? So you think about being in a dream and having various different moods in your dream. You can't identify one global state of consciousness with various moods, right? Moods come and go. We have different temporal profiles, and you can be in many different moods and remain in the same global state of consciousness. So that's what I have to say about mood so far. It's just that they're sort of distinct phenomena, but nonetheless, they might have sort of things phenomenologically in common, which might link, might explain why people have thought that depression is a mood disorder. And here you might just point to the sort of globality of moods, is what philosophers of moods talk about, the sort of global, all-encompassing, sort of, you know, I don't know how to describe it, but
you don't think that it's like, you know, your mood changes a bit and that's it, and then you get, you know, some kind of threshold, over some kind of threshold of collective mood changes, and then you've got a different global state.
I think that's a hypothesis about the changes of what brings about global states of consciousness, which I'm open to, but would be, I'm unsure. I can't think of any other one other than depression, of which moods would, meditation might be the, but again, it's not clear what, a sort of very interesting question is what brings, so meditation I'm fascinated by because it's one of the only global states of consciousness transitions that you have some sort of mental agency over. And so anyway, interesting question there, but yeah, that's open to that being the case. What was the other one? Aha, the degrees, yes. Okay, so first thing to say is that sleep and wakefulness are not binary phenomena. This is the case in both conscious experience, so when you think about the transitions between sleep and wakefulness, and think about hypnagogic imagery, there's lots of conscious experiences which occur on the borderline. And there's also a case neurobiologically, so there's lots of work going on about what's called local sleep, so sleep which doesn't seem to be a sort of whole brain phenomenon anymore, only limited to certain parts of the brain. And so this is throwing up lots of interesting questions about natural kinds, about sleep and wakefulness. So So that's the sort of answer to that about. But I should say that I think even then, so that's really getting at sleep and wakefulness in a biological sense, not necessarily getting at the what I think are quite dissociative concepts, which are these states of consciousness. Yeah.
Okay, let's take another one from the chat. That was the first one. That was the first one. So the second one from Wilma. Thank you for sharing this inspiring perspective on understanding depression as a human condition. I wondered what biomarkers of depression in biological psychiatry you referred to.
When did I refer to? Did I refer to specific ones? Or did I just mean general ones? So I don't think I did. So maybe it's just a question about what they are. So yeah, so there are a variety of different biomarkers. And again, big worries about which ones are the best and which ones are the most predictive. So a big line of research at the moment are sort of inflammatory markers, which is so this there's this great book which I recommend on the inflamed brain, I think it's called. I always hate to recall things at the last minute. But basically you can go out and look at all of these different ones. I think the inflammatory, the work which has been done, which I think is the most useful on sort of this predictive onset, is these inflammatory markers. Yeah, I don't want to speak to the other ones in case I upset people.
Okay, good.
And thank you for the talk. It was beautiful, and I don't know much about this. There is a question, and we don't even know if it's like affecting your argument or like, but just interested me if there are some studies about possible effects of the presence, this kind of global state of consciousness when people are sleeping, so like in dreams and so on. So like I don't know really say that it's connected to what you're saying, because if I answer correctly, like depression would be like state of an unreading, because but given this kind of global effect, yes, doesn't implies that it could affect also how we, for example, dream. There are studies about this.
Yeah. So there are loads of studies actually. So
For the,
sorry.
for the people
This
listening
is
remotely.
throwing me off.
I know, it's really
It's great.
so the question was how to fit in the effects that depression might have on dreams, right? So that's sort of
Yeah.
If
If only I could adopt this amazing way of thinking and talking instead of rambling. So there are, I guess there's lots of studies done on this actually. So when I started working on this, I was sort of aware that there was some connection. Only in the last few months have I really read a lot about it and realized that there is like really substantial biomarkers, not only with respect to sort of REM sleep changes, but also with dreams. So, I mean, I sort of knew anecdotally that lots of people said, oh, I have horrible dreams, I have nightmares when I'm depressed. But now it's, I suppose it's, I don't want to say fact, because what are those? But there's data which suggests that, yes, there are strong changes to the content of dreams when individuals are depressed, right? So the question, I guess, is what does my view say about that, right? And I think that what I will say about it will depend very much on exactly how I'm thinking about the relationship between global states of consciousness and the sleep-wake cycle. So I suppose I'm moving towards a view which the two are much more tightly connected than I had thought. And in that case, so you think that there's a sort of, I don't want to say regulation is a very strong word, but regulation of standard global states of consciousness by the sleep-wake cycle, it would make sense that this would mean that the sort of the causal etiology of depression is going to be in some sense connected to the sleep-wake cycle. And that would explain why there'll be changes in not only stages of the sort of neurobiology of being awake, but also in the stages of sleep. And that might explain the different phenomenology of different dreams. So, I mean, on a somewhat epistemically non-humble, is that the word? Way of speaking, I would be inclined to say that it's likely that they're actually not in the same kind of state when they're asleep as normal healthy people. But that's, yeah.
Yes, I also thought it was very interesting. I think related questions, but it's possible that what I say about effects is completely wrong, because I don't know anything about the state. So I wonder how your globe states model kind of relates to what I believe to be the may be wrong. Or you can speak louder.
No, so I think just there's some noise I can hear.
Okay. So I believe that to be these two empirical facts about depression that it may be wrong, and so correct me. But if they're right, I wonder how your global states of depression kind of connected them. So I thought it was quite well. So what is the kind of reports that you get? Well, it's probably now kind of all both, like the distinct process from people who take antidepressants and find that they work, kind of say that they have themselves back, right? And so there's this kind of notion of the depressed state being not the real self. You know, maybe in a way that we also just sometimes think of a drug state or a level state or a high state, whatever, isn't the real self. And the other thing was in relation to the reset idea. So I believe that electroshock therapy, which of course sounds pretty brutal, is still used as last resort depressant thing, and is deemed effective some of the time. And I mean, I don't think we know exactly what electroshock therapy does, but if it does anything, it sounds plausible that it is sort of general reset.
Yeah.
Let's summarize again. So two questions that relate from that sort of stem from two observations or sort of empirical facts. One is that people sometimes describe depression as not being themselves, not being their real selves. And the other is that electroconvulsive therapy is used and often thought to be effective for depression. And how can we accommodate these two observations?
Yeah. So yeah, I think these are both really, really good questions. So on the self question. So yeah, who knows? Who really knows what the self is, right? So what I would say is that, like you were talking about drunkenness, so one of the sort of phenomenological dimensions of these states of consciousness shifts is changes in self, right? So the most radical one being the ego dissolution, which you see at high dosages of psilocybin and psychedelics. So I suppose my view would be able to accommodate that there being robust changes in the sense of self. I'm not sure what I'd say about being the real self. I guess you can ask similar questions about the dream self. This is what philosophers who are into dreams talk about, the dream self and how does that relate to the waking self. But I think that the sort of similarities here are all sort of good for me, good news. But yeah, so not really too much to say about how exactly the concept of a global state of consciousness relates to the concept of the self. Yeah, like I suppose I can see one view, which maybe I'll just say, which I don't endorse, but I can see people going along these lines, is that you might think that there is a sense in which being awake in a distinctive state of consciousness, wakeful consciousness, provides one with a very distinctive point of view on the world, which might have things to do in common with oneself. So that's what I'll say about that. But with regard to they've got the convulsive shock therapy, and there's also really good work on deep brain stimulation and depression. And yeah, I guess I haven't looked into it too much yet, but it seems plausible for exactly the same reasons, that it would be a sort of shaking reset, which would disturb the causal mechanisms underlying this sort of entrenched depressive state of consciousness, and yeah, in the same way bring about the same result. But like you said, it's kind of the thing why it's kind of hard to look into it is because there's no real explanation as to why it's working. It's just sort of done. And yeah, which is good at least. Welcome.
Cool. We still have 5 or so minutes left, so let's go back to the chat. I think there's at least 1 or 2 other questions in there. So where did we get to? We've had that one, we've had that one. Okay, so the question is depression a unitary condition, and will it apply to only a subgroup of depression? What about bipolar disorder, two different types of consciousness disturbance?
Yeah, great. So this is the most common question I get, which is, what about other mental disorders? And mostly actually it's about schizophrenia. So I had some psychiatrists be like, why did you start with depression? Like, if you're wanting to bring about this shift in thinking about mental disorders, you should have started with like schizophrenia. So what do I have to say about that? So yeah, so one of the studies that I mentioned about using this, what's known as the perturbational complexity index, which is this just a correlate of global states of consciousness changes, which is measured using TMS. One of the sort of studies which are in the funding stage is actually looking at schizophrenia and that along exactly the same lines. But yeah, so in general, I'm very open to it being a much broader phenomenon than depression. I think partly because I already feel so wildly ambitious that I really just cannot bring myself to say anything more broader about psychiatry than I already am. But for sure, I think that there are lots of other mental disorders, but definitely not all, which might benefit from elucidation in these terms. And yeah, what would that mean about subvariety? Yeah, it all just depends. So for example, you're talking about this sort of specifier or the mixed that with bipolar and various sort of related conditions. So yeah, I guess the most natural thing I want to say is that this picks out a sort of distinctive state. So that sort of brings in line with the sort of question, the answer to a question I said earlier is that it's likely that when we're talking about depression, we're picking out this distinctive family of states, but they're all unified in the sense that they're all disorders of consciousness. So I suppose these sort of subgroups of depression would be in line with that.
Okay, so there are a couple of hands raised. Jay, are you able to unmute yourself?
You read out Jay's question before.
Oh, I think
So that could be the same. That could be an old hand.
so. I think Tom has a question.
Yeah. Okay. So if Jay isn't going to ask a separate one, then perhaps we'll go. Yeah.
Thanks. So this was a question that touches on some material that you just talked about in discussion. When we think of a state being disordered, we usually think that something's broken down or it's gone wrong. So I wonder whether thinking about depression as disordered rules out a priori the idea that the state might be somehow adaptive. So you talked, for example, of the inflammation hypothesis, and I take it that someone who thinks that depression is some determinable of inflammation would want to say, well, look, well, might look like something has gone wrong, but in fact it hasn't. It's working as it's supposed to work. So I just wonder if you could comment on that.
Yeah, interesting. Yeah. So yeah, so how I initially set things up, I wanted to stay very neutral on what it means to be a disorder. So framing it as a disorder of consciousness was supposed to be helpful insofar as it might help people who are familiar with disorders of consciousness to know what I'm talking about. So with that, maybe there's a problem insofar as it looks like I'm committed to something about the sort of the dysfunctional nature of depression, which I didn't want to be. So I think that I would hopefully it'll be compatible with. Do you think there's a reason for thinking it's not compatible with that, right? Or is it just a matter of?
I suppose that one of the things I was getting at is to get you to say a bit more about the kind of distinction that Matt makes in some of his work and the kinds of things that I've bought into, where you might think, look, there's some kinds of, I mean, you've talked about disordered states, but then also about disordered consciousness. There's a question about whether they're exactly the same thing. So one very easy way to kind of kick my question into touch would have been to say, look, disorder of wakeful consciousness is one thing. Disordered state and is kind of another. So think, for example, I mean, yeah, that was the thought.
Yeah, I'm not sure. I think we'll have to chat. I'm not clear what I want to say about that. Yeah. I mean, you know, in some days I'm very clear in the sense that being the disorder that I want to, what I'm getting at in terms of the disorder, I think, is in the sense of, I think depression takes this place of wakeful consciousness, and wakeful consciousness is likely to play a variety of different functions. So, in the words of Harriet, who I know you had here, it's like the domino of the various. Anyway, that doesn't mean anything to you, Tom. I'm sorry. This is really not being helpful. Basically, I think it sort of plays a variety of different functional roles. So. And I think depression is taking the place of that thing, and it's going to prevent it from playing the variety of roles that it does. And that's going to be a sort of to be understood in a network of a variety of different functions. But yeah, we can chat, because I'm not sure about the state versus.
Thanks ever so much. No worries.
But thanks.
Okay, that pretty much takes us to time. So apologies to those who had questions in the chat that we didn't get to. The good thing is we can sort of save those and pass them on to Cecily, so she can read them anyway. But yeah, that is time. So all that's left is to say thank you very much.
Thanks for having me.